My name is David Schuster. I am the Division Director of Nuclear Medicine and Molecular Imaging at Emory University in Atlanta, where I am a professor. When we think about interpreting PET well, one should be familiar with the imaging features of false positives on PET-CT. And typically I'll be talking about FDG PET, but this goes for any PET. Now, I give two separate hour-long lectures on this topic. I tell my residents not everything that is hot is cancer, and that interpretation is all about context. So for example, let's say someone walks in off the street and has moderately intense marrow and spleen activity. Then we may suspect lymphoma involvement. Yet, if they had been administered G-CSF within a few weeks before, that will give the same appearance. A systemic infection may also have activated marrow and spleen. Now, when available, we always read the oncology note. Also, looking back at the oldest scan to see how disease first manifested is helpful to determine then what the study may look like in follow-up and where recurrence may occur. Let's say a lymphoma patient first presented with nodes above and below the diaphragm, but nothing else, then undergoes systemic therapy, and all the nodes are improving. But then the patient presents on their latest PET scan with new FDG-avid lung infiltrates. Well, that is overwhelmingly likely to be infection from chemo-related immunosuppression or possibly inflammation from certain therapies, systemic therapies. We should also be aware that the new immunotherapies may have a flare. That is, the patient is actually improving, but the lesions themselves look worse after the first round of immunotherapy. They may at first take up more FDG as a reaction to the immune activation process. In fact, this is an area of active research. On that note, we have also seen a sarcoid-like post-chemotherapy reaction whereby symmetric mediastinal and hilar FDG avidity is seen, which can also involve the spleen and other organs. The bottom line is that there is no one distinguishing imaging feature, but one must have knowledge of a library of potential false positives and understand if the finding makes sense as benign or malignant within the clinical context.